Hi everyone. As Richard said, I'm Amy Haynes. I'm the Cancer System Innovation Manager for Illawarra Shoalhaven Local Health District. Before I start, I want to acknowledge the traditional owners of the land that we're meeting on and pay my respects to elders past and present and future. And I'm going to talk about a recent project the Illawarra Shoalhaven's colorectal cancer MDT, or multidisciplinary team, has undertaken, and that's the implementation of comprehensive outcomes measurement for rectal cancer patients. This project has come off the back of a number of years' work by this very engaged group of clinicians. Our project has been to implement the International Consortium for Health Outcomes Measurement, or ICHOM, standard outcome set for colorectal cancer. And for those who are not aware, ICHOM is one of the key international proponents of value-based healthcare, and they produce these standard outcome sets which are arrived at through consultation with clinicians across the world, and importantly with patients as well. And as you can see, the largest group of outcome measures there in the slide is actually the patient-reported group. But I'll come back to those in a moment. And also to say we got a Cancer Institute grant to implement this project, which has been very, very helpful. So the ability to collect quality data was an important prerequisite to this project. Over the last few years, we've built data collection capability into all of our cancer MDT processes through online referral, through the use of live mosaic, that's our oncology information system, MDT documentation. And for rectal cancer, we've had a passionate radiation oncologist, Dr. Charlene Kang, who's done an incredible amount of work to complete a set of rectal cancer data for all Illawarra Shoalhaven patients diagnosed between 2006 and 2017. So 12 years worth, all diagnosis, treatment and follow-up data, and it's an incredible resource. And the final building block for collecting the ICHOM measures was to implement prospective collection of the patient-reported measures, which of course is where most of the work has been. The other prerequisite to collecting outcomes data is a structured follow-up process that you can tie your measures collection into. And the first thing the MDT did in this project was to agree on an evidence-based standardised follow-up process. And this is the follow-up protocol for early stage colon and rectal patients. So as you can see, the clinical follow-up is at the top, along the top line, represented on a timeline up to 5 years. And down the bottom you can see we've tied the outcome measures collection into that clinical follow-up. So when a stage 1 or 2 rectal cancer patient comes to see their surgeon at the 1-year mark, the surgeon knows he or she has to do a colonoscopy, a CT, a CEA, and collect the patient-reported and survival and disease control measures. So I want to tell you a little bit more about the measures we've been collecting before I dive into the results. First up, the survival and disease control measures. They're things like overall survival, recurrence-free survival, as well as important prognostic factors like tumour regression score and margin status at surgery. We're collecting the majority of these measures through MDT data collection. We're also collecting measures about the short-term complications of surgery, radiotherapy and chemotherapy, and these measures are collected directly from clinicians via surveys at the 6-week mark post-treatment. For the patient-reported measures, we're using 2 EORTC quality of life surveys, the general C30 and the colorectal specific CR29. Clinicians get their patients to complete these at routine appointments, as per the follow-up protocol I talked about earlier. And we're also collecting a baseline comorbidity measure. This isn't part of the ICHOM standard set, but we're interested to see how comorbidities affect our outcomes in the longer term. And in general, in our MDTs across our district, we've been having some discussions about how we better take comorbidities into account when making clinical decisions, so that this ties in with that as well. And we're collecting all of these measures for all rectal cancer patients, new and existing, in our region, in the public and private sector, and we have all of the relevant clinicians involved. Now to talk about the reason we're collecting the outcome measures, just answer some of the hard questions. How effective is our care? How likely is it that our patient's disease will recur? How much variation is there within our own teams and our district? How does our care compare to services in New South Wales, Australia and overseas? And how will the care we give impact on our patients' lives into the future? Sorry. In terms of results, beg your pardon, there are 2 slides in there, I didn't realise we're in there. In terms of results, the first thing I want to highlight is that this work and the data we've collected has given the MDT a much better understanding of the cohort of patients in our region that it cares for. That understanding is, I think, an important part of the notion that the Cancer Institute describes as oversight of a group of patients by an MDT. For example, one important thing we've learned is that our rectal cancer population is significantly older than populations cited in the literature, and about 10 years older than key clinical trials populations. And this is important when you start to benchmark your outcomes against other services. We know also that our most common stage at diagnosis by quite a long way is stage 3. As I mentioned earlier, we have a complete set of data for 644 patients with a median follow-up period of 4.2 years. This means we know how well our patients do. We're still in the process of analysing our data, but we have presented the data a couple of times recently to the MDT, and clinicians are uniformly captivated by it. I remember the first time Dr. Kang presented our survival curves to the colorectal MDT. You could have heard a pin drop. These are our recurrence rates for stage 1 to 3 curative patients. But in order to evaluate your own performance, you have to know how well others are doing. To our knowledge, there's no other cancer service in New South Wales or Australia who has published their survival and disease control data for rectal cancer. But in an international context, our local recurrence rates are comparable. And the studies in blue here are very big studies and probably offer the best benchmarking opportunity, we think. And this is our distant recurrence rate as compared to published rates internationally. But it's not only the outcomes data itself that's powerful. The process of evaluating our outcomes has brought about a focus on all aspects of rectal cancer care. One example of this is the streamlining of colon and rectal follow-up. Another example is that several of our clinicians have become expert in cutting-edge thinking in rectal cancer management. They've been to specialist courses run at world-leading centres with world-leading clinicians. And this project has also led us to improve rectal cancer diagnosis in our region. As a project steering committee, we wrote to all of the imaging providers, public and private, in the Illawarra and Shoalhaven to request that they adopted a standard synoptic reporting style for rectal MRI and to ensure that important prognostic features were highlighted. We also provided them with guidelines and a reporting template from the Society of Abdominal Radiology, and we did a similar thing for standardised reporting of histopathology, and also supported the MDT's pathologists to advocate for the routine use of additional stains in evaluating rectal cancer. I want to talk for a moment about the power of outcomes data to translate to improvement in care. Of course, now that we know our district rates of any of the survival and disease control measures, we can also separate out our individual clinicians, our treatment centres, and our patients' places of residence. This is an enormously powerful tool for improvement. I've put up a dummy graph there. Obviously, we do know our real local recurrence rates for our surgeons, but I've put up the dummy graph because in our district we're only at the beginning of this process of using our data in this way, and as we talked about at the workshop yesterday, governance around this very sensitive data is extremely important, and we want to get that right. The graph on its own, though, is not that remarkable. After all, local recurrence is only a small part of the total recurrence picture, but what we're finding is that all the different elements we measure fit together like a puzzle. And as we analyse our data, the picture of what's really happening is becoming clearer. And we wouldn't have known any of it if we hadn't been measuring our outcomes. But measuring outcomes is not enough. Our next challenge is to facilitate the regular use of this data by our clinicians and leaders in our health service. We're currently working on a reporting framework which reflects the key elements of rectal cancer care. But when you have so much data, there's a danger you can drown in it. So what we're trying to do with the framework is only reflect those factors that have a really significant impact on rectal cancer outcomes. And this is just a small excerpt from the framework, the colorectal specific quality of life measures. We're also working on the governance around our data. It's important we have a structured approach to what we release and to whom, and how we use the data within our district's clinical governance structures. We're also building the Cancer Institute's reporting for better cancer outcomes measures into the framework. And this work has also led to a number of further studies using our retrospective data, but also in the genetics of rectal cancer. And lastly, I want to pay tribute to our steering committee and leave you with a quote from one of our colorectal surgeons, Dr. Sunny Putness, who in one of our earliest steering committee meetings declared, "This is not a study, it's part of everyday practice. It's what we should all be doing as part of normal care." Thank you.
Thanks, Amy. We've still got time to kick off a few questions.
Hello, my name's Jan Mumford. I'm the chair of the Consumer Advisory Panel for AGITG, which is the Clinical Gastrointestinal Trials Group. I think of Shoalhaven, Illawarra as being a retirement area, so maybe the over 70 figure didn't surprise me too much. But what about people under 50? Was there any younger cohort shown?
Actually, there were relatively few patients under 50, only from memory 3 or 4%. Relatively few. This is for rectal cancer only though. Our data's for rectal cancer, not for colorectal. Yeah.
Hello, I'm Verity Ahern. I'm interested to know whether you've got a similar program running across all your tumour streams in Illawarra.
Oh, if only. As you would know, and I touched on it briefly there when I talked about Dr. Charlene Kang, who's been really the data custodian for this rectal cancer data. She's got a passion for it, and the significant investment of her time has been fundamental to being able to measure these kinds of outcomes. But having said that, I think something like this is very key in demonstrating to people the importance of measuring outcomes. And actually, what we're trying to do through this project is all of the processes we have in place in terms of, you would have noticed I said a lot of the collection was actually through clinicians themselves. We're not having everybody else in the team do that work for them, so that clinicians are really bought into the process. They want to know the outcomes. So a lot of the collecting the follow-up data for patients in that 5-year follow-up period is just through routine appointments with clinicians, and if those collections are done at that time, then we will have the follow-up data for patients who are on this study in the future. But yes, it's a significant investment.
Thank you for your presentation. I just wanted to know, how are you actually feeding back this information to the clinicians? And secondly, how has it actually been received by the surgeons?
Thanks for the question. As I mentioned, we've presented it back to people in the context of the colorectal NDT, so that group of clinicians. Obviously not the local recurrence rates and any performance type indicators by clinician themselves, because that data belongs to that person. And we haven't actually fed that back to them either yet. We have a steering group, and I think we're really at that point where we've just got a hold of all of this data, and we've just done the analysis in the last few months. So as a steering group, we're really mindful of the importance of the governance around that and tying that into the district's clinical governance structures as well. So that's a work in progress, but we've shown them the survival curves and all that sort of thing. But that's why we're developing the framework as well. We really think it's important to have a structure around that. So that framework will determine when different things are reported back through and through which means as well. Yeah.
All right.